Good afternoon, good evening, dear colleagues. Welcome to this webinar organized by Young Internists group of the European Federation of Internal Medicine, with the leadership of our chief, Carina Mihai from Romania. I'm Gabriele Vassallo, an Italian internal medicine consultant, a member of Young Internist Assembly and a board officer of Young Internist Group of our federation. Together with my colleague Max Schuller from the Internal Medicine Department at the University of Graz in Austria, we will moderate this webinar on systemic sclerosis. Before starting, I would like to provide you some technical details about the webinar. After the introduction, there will be the lecture of Professor Mihai, and once the lecture will be over, we will start the discussion. Because your microphones have set mute, you can ask your question through the Q&A button that you can easily find below on your screen. The questions will be addressed to the speaker at the end of her presentation. So I pass the word to my colleague, Max Schuller, to introduce the speaker and the topic of this webinar.
Thank you very much, Gabriele. Warm welcome from my side. It's now my great pleasure and honor to welcome our speaker today, who is Professor Mihai. She's an internationally renowned expert in the field of systemic sclerosis, which this presentation will be about. Professor Mihai received her medical degree at the Carol Davila University of Bucharest, Romania, where she became an assistant professor in internal medicine and rheumatology in 2000. She began clinical research as a fellow in the rheumatology clinics of Maastricht and Radboud in the Netherlands during 2001 and 2002. And she received her PhD title in 2006 from the Carol Davila University of Bucharest with a thesis on systemic sclerosis. In the same year, Professor Mihai founded the Center for Systemic Sclerosis of the Cantacuzino Hospital of Bucharest, which is a European scleroderma trials and research center. And she headed this center until 2017. Professor Mihai's research focuses on predictors of disease worsening in systemic sclerosis, disease outcome measurements, and study design. And she has published many high-ranking articles in high-ranking journals. Since 2017, she works as a rheumatologist at the University Hospital in Zurich, where she leads in the outpatient clinic for systemic sclerosis patients, and she also continues to do research in systemic autoimmune disease. Furthermore, she habilitated at the University of Zurich in 2022, and we're very grateful that Professor Mihai will be here today with us. And without further ado, I would like to pass the virtual stage to her for her presentation.
Thank you for the kind invitation and for the very kind introduction. I am very pleased to talk today at this EFIM Young Internists webinar about systemic sclerosis. My title is quite broad, a primer for the internist. So I will try not to be very boring at this late hour and to show you the most important aspects in systemic sclerosis without getting into too much of a detail, but still keeping the big picture in mind. So these are my conflicts of interest. And before I go into the clinics of systemic sclerosis, I just have this slide on the pathogenesis of the disease. I want to remind you that it is an autoimmune disease, a systemic autoimmune disease. It's characterized by disease-specific anti-nuclear antibodies, Some of them are long time known, like the anti-SCL70 or anti-topoisomerase antibodies. The more newer name is anti-topoisomerase. Also, anti-centromere antibodies are known since a long time, but the list grows from year to year. Now we have the anti-RNA polymerase III antibodies, which are quite specific for the disease, and with the other two, they are the so-called disease-specific antibodies. I have to point here out that these anti-RNA polymerase III antibodies are also a marker of neoplasia. About 30% of patients with these antibodies might develop cancer or might already have a cancer. There are other disease-specific antibodies, and immune dysregulation and structural and functional alteration of microvasculature are the first pathogenetic events in SSC.
Sorry, Professor, for the interruption. Could you share your screen because we couldn't see?
I'm so sorry. I apologize.
Thank you.
So, yeah, it was another click to make, which I didn't do. So, if microvasculature is the first involved and the immune system is already dysregulated, in some of the patients, we shall see fibrosis, which can involve the skin and also some internal organs, the gastrointestinal tract, the lung, the heart muscles, and we also might see inflammation. We might, but we don't have to see fibrosis and or inflammation in all patients. So much for the pathogenesis. So with the next slide, I would like to introduce you to the very complex clinical picture of organ system involvement in systemic sclerosis. So if you keep the pathogenesis in mind, we have on one hand vasculopathy, which is present in the majority of patients because over 95%, almost 100% of them do have Raynaud's phenomenon, only a minority don't have it. Other vasculopathic features, less frequent than Raynaud's, are finger lesions, fingertip lesions, finger ulcera, also pitting scars, and more rare vasculopathies involve internal organs. Fortunately, these are not so frequent, like pulmonary arterial hypertension in about 10% at most, and renal crisis in currently about 5% of patients. These are very severe complications of systemic sclerosis. Actually, we should not call them complications because they can be part of the clinical picture, and they have practically a vascular mechanism. Fibrosis, as I said, we most frequently see it in the skin, where it mostly begins in the fingers with sclerodactyly. It was also very prevalent in the gastrointestinal tract, where it leads to dysmotility. And we may see it in other internal organs like lungs and heart, where it comes with a very severe prognosis in some patients. And last but not least, we may see inflammation, like joint inflammation, arthritis, and less frequently muscle inflammation, myositis. And we also can see inflammation of lacrimal and salivary glands reflected clinically into the Zika syndrome, which is similar to that seen in Sjögren's syndrome. And of course, like in other connective tissue diseases, Sjögren's syndrome is a frequent association to systemic sclerosis. We define these two subsets of the disease based on the presentation of skin fibrosis. I would like to remind you that in systemic sclerosis, skin fibrosis begins in the fingers, and then it progresses more proximally. And if it doesn't affect the trunk or the proximal extremities, then we call it limited cutaneous systemic sclerosis. And it has a better prognosis than the diffuse cutaneous subset, where at least one of the central areas is affected, like thorax, abdomen, and proximal extremities. The fingers are always involved if fibrosis occurs. And if they are not involved and we see pronounced fibrosis elsewhere, we have to think of a differential diagnosis. These so-called scleroderma mimics are even more rare than systemic sclerosis, and they can spare the fingers. So keep this in mind. When fibrosis begins in patients with systemic sclerosis, it begins in the fingers. When it affects the fingers and progresses more proximally, involving the skin in the hand, in the dorsum of the hands, we already have the major clinical criterion. It is called proximal from the MCP joints systemic skin sclerosis. So skin sclerosis affecting proximal skin, proximal to the MCP joints, is practically diagnostic for systemic sclerosis. I will come back to this when I shall discuss the classification criteria of the disease. And before finishing this introduction, I would like to mention the EUSTR collaboration. EUSTR stands for European Scleroderma Trials and Research Group, and it is born as an effort of the Schuller, of the European Association of Rheumatology Leagues, 20 years ago, because this is the connective tissue which the worst prognosis with the least treatments. It then was practically with very few treatments 20 years ago. And this worldwide collaboration, which now has over 250 centers on all continents and a database with over 22 patients in it, this collaboration has led to a lot of progress in the field of systemic sclerosis. And this is a EUSTR study looking at mortality from my colleague Muriel Elhai, and it was published 2017. It looked on various disease-related and non-disease-related causes of death. For instance, atherosclerosis, which is a very frequent cause of death in the general population. We can see it is not so frequent here in systemic sclerosis. The most frequent disease-related cause of death is lung involvement. And lung involvement can be vascular, like pulmonary arterial hypertension, can be lung fibrosis, or a mixture of the two. Another important disease-related cause of death is primary cardiac involvement, and atherosclerosis-related cause of death comes in the third place. So with these data, systemic sclerosis is the connective tissue disease with the worst prognosis. It has a higher mortality than lupus. It has a higher mortality than Sjögren's syndrome. And it is a reason why we should do more treatment research and find how to treat it better. This brings me to the agenda I would like to cover tonight. So I want to cover these four most important points: how to diagnose the disease early, how to follow up patients, what should we avoid, so what should we not do in these patients, and how can we treat the disease. How to diagnose early. In the vast majority of patients, like over 90%, the first symptom is Raynaud's phenomenon. Of course, we have to keep in mind Raynaud's, it's not specific to systemic sclerosis. It has so many other possible causes, and the most prevalent cause of Raynaud's phenomenon, it's still primary Raynaud's, like Raynaud's disease, which is a benign condition. But patients with connective tissue diseases, and among these patients with systemic sclerosis, have a high prevalence of Raynaud's phenomenon. And this is also a reason why we are considering the disease onset in two ways in systemic sclerosis. We consider the date of Raynaud's phenomenon as one onset, but because Raynaud's phenomenon can last for years before other symptoms occur, we also consider the first non-Raynaud's symptom as the real start of the disease. So in this slide, I have gathered the various vascular manifestations in SSC. As you can see, the most prevalent is Raynaud's. About 80% of the patients have specific changes in nail fold capillaroscopy called the scleroderma pattern. I shall come to that. About over half of patients have telangiectasia, especially in the face and in the palms, in the hands. About up to 50% of patients develop in the course of the disease finger lesions like fingertip ulcers or other ulcers on the fingers, like on the back of the fingers, also pitting scars, and less frequent peripheral vascular manifestations are distal artery occlusion, like arteria ulnaris occlusion, and digital critical ischemia and gangrene. Also, due to vascular changes and especially to capillary leakiness, in very early stages of the disease, we meet puffy fingers. These are swollen fingers. The swelling occurs in all fingers, and it is not yet fibrosis. And in these patients, puffy fingers may evolve to sclerodactyly, to fibrosis, but also it may not evolve. It may just stay as it is or even improve. So remember, puffy fingers is a very early feature of disease. It does not tell us anything about how it will evolve into more diffuse, into fibrosis or not. But in patients who present with Raynaud's phenomenon and puffy fingers, we have to keep in mind that they might develop systemic sclerosis. In the other photograph, you can see a patient with established disease. She has skin fibrosis, and she also has very many fingertip lesions. Here is an open ulcus. Here is an ischemia, which leads probably to skin necrosis. And this finger, this second finger, probably has a shortening of the distal phalanx, something we call acroosteolysis. Because of chronic ischemia, the tip of the distal phalanx gets resorbed. How do we diagnose Raynaud's phenomenon? We do it on history. We don't have to provocate it. We just have to ask the patients if the fingers are unusually sensitive to cold, if the fingers change color when exposed to cold temperatures, and then if they become white or purple or both. A yes in all three questions means it's definitely a Raynaud's phenomenon. A yes in two questions is probable Raynaud's phenomenon, and a no in two questions means no Raynaud's phenomenon. Sometimes we show in the computer patients some images of Raynaud's crisis to make sure they have it or they don't have it. So we base it on history. And another thing to do in patients with Raynaud's phenomenon, where we want to look if they might develop systemic sclerosis or another connective tissue disease, is perform the periungual, the nail fold capillaroscopy. We might do it with a capillaroscope, with a video capillaroscope, which is a handheld device, or with a stereo microscope. And what we are actually looking for are giant capillaries, like the one you can see here, and capillary rarefaction, capillary loss, which is also accompanied by a disturbed architecture of the capillary network. So one of these or both of them means we found the scleroderma pattern, and we think the patient might get systemic sclerosis. In clinical practice, there is an easy way to look at capillaroscopy. So we look at the pictures, and if density of capillaries is at least 7 capillaries per linear millimeter, and if there are no giant capillaries, then there is no scleroderma pattern. So this helps us to rule out the scleroderma pattern. If we see changes like dilated and giant capillaries, then if there are giants, that is the scleroderma pattern. Or if we have no giants, but we have extremely lowered density, we also can classify the patient having scleroderma pattern, also if there is some disturbance of the architecture of the capillaroscopy. Let me show you an example. So here we have 3 pictures from 3 patients. On the right hand, we see a normal capillaroscopy, nail fold capillaroscopy with very thin capillaries with a normal density. And when we see this, there are no giants, no dilations, no missing capillaries, it's normal. In the picture on the left, we see giant capillaries. Also, the number of capillaries on millimeter is decreased. So this is the scleroderma pattern because it meets both criteria of giants and rarefaction. It would have been enough to see one of the 2 criteria to classify it as scleroderma pattern. But in a certain number of patients, we meet with non-specific abnormalities like dilated loops and microhemorrhages. And this is non-specific. We have to check for other clinical symptoms, other signs of the disease. If we don't see that, it might be a healthy person. And in some patients, we tend to repeat it yearly to be sure the Raynaud's is not connected to systemic sclerosis. This brings me to this very nice Canadian study where the researchers looked at patients with Raynaud's phenomenon of unknown etiology. They did it for a long time. They had a median follow-up of 4 years. And in this table, they classified patients into patients with normal capillaroscopy and negative antibodies. With negative antibodies, I mean they didn't have the scleroderma-specific antibodies. And in these patients, the probability they develop systemic sclerosis over 10 years was below 2%. They had Raynaud's, but they didn't have the capillaroscopy and they didn't have the antibodies. So the probability is very, very low. If they have both SSC-related antibodies and the capillaroscopic scleroderma pattern, then over 70% developed SSC over 10 years. So these patients with Raynaud's and positive capillaroscopy and antibodies, we call them very early systemic sclerosis if all other features are missing. And the other 2 categories with only positive antibodies or only positive capillaroscopy, they still have some chance to develop SSC in 10 years, like 20 to 30%. But the reverse is the other 80 to 70% will not develop SSC over 10 years. So this is the gray area. Let me illustrate with a case. This is a young female patient, 16 years. She has a newly developing Raynaud's phenomenon. It's progressively worsening. She had a recent ulcer on her second finger of the right hand. She's a smoker. In the clinical exam, we don't see the ulcus anymore because it has healed, but we see a pitting scar actually also on the other second finger of the other hand. Otherwise, the clinical exam is normal. We performed the capillaroscopy. She has the scleroderma pattern, and in the lab, there are anti-centromere antibodies present. So this allows us, with all these features and the pitting scars, we may classify her as having a mild systemic sclerosis, even if the fibrosis is missing at this point. These are the anti-centromere antibodies in immunofluorescence. So to move forward, these are the 2013 classification criteria for systemic sclerosis. They have been updated because in the old criteria, 1980, we only had skin fibrosis and digital tip lesions like pittings, like ulcers and interstitial lung disease. Now we have to take into account that patients that do not have any fibrosis still may have systemic sclerosis. So in red, I have highlighted vascular changes that are new to the criteria, that are not present in the old criteria, except interstitial lung disease, which I should have colored in black here. How do we use these criteria? Actually, they are not thought for diagnosis, they are thought for classifications. They are divided into these domains, and from each domain, in some domains, we can pick up the criterion which weights most, like if both ulcers and pitting scars are present, we shall check 3 points for pitting scars. And with 9 points in total, we can classify the patient as having systemic sclerosis. So you can see that Raynaud's phenomenon counts, disease-specific antibodies count, nail fold count, even telangiectasia count, and also the most specific features like ulcers and skin sclerosis have a big importance. So in this patient, to finish with the case, she has a mild form of the systemic sclerosis, and we recommend her to stop smoking, to protect from cold, and we might begin with nifedipine, with calcium channel blockers, to control symptoms. It is not mandatory. It is adapted to her life quality. If she needs medicine, if the Raynaud's is really disturbing, then we would institute medical drug treatment. And another important thing we have to tell her is that she needs a yearly assessment to screen for organ system involvement. This will bring me to the point of how we should screen, how we should monitor patients with systemic sclerosis. And to finish the discussion about how to diagnose early, this is the concept of very early disease. On the left side, colored in dark blue, you can see the features of very early disease, Raynaud's phenomenon, puffy fingers, and disease-specific antibodies and capillary changes. We would like to have a treatment that we could institute here in this hypothesized window of opportunity. We don't have this treatment yet. The window of opportunity is a concept we are actually borrowing from rheumatoid arthritis. We know that there, if we treat very early, we can achieve a better and long-lasting remission than if we treat an established disease. Then the disease, if it has a natural course to early SSC, and in some patients fibrosis occurs, and in some patients fibrosis leads to severe organ system involvement. So we would like to diagnose early, to treat early what we can treat. This will be shown in the point 4. But before we can treat, we need to diagnose organ system involvement. And this means we have to follow up patients. And we are recommended to do this annually, yearly. In some patients, we even monitorize more frequently if they have if they are attained in the life in internal organs with very severe prognosis, but in all patients, we should look annually. And these are the domains that a group of experts set up in a Delphi-based consensus. So you can see we are checking on peripheral vascular phenomena like Raynaud's and finger lesions. We are checking skin. We are doing this by performing the modified Rodnan skin score. We are checking musculoskeletal symptoms like joint pain, joint inflammation, synovitis, signs of muscular inflammation like muscular weakness and CK, creatine kinase elevation. And we are also checking internal organ involvement, lung involvement, heart involvement, gastrointestinal tract involvement, kidney involvement, laboratory, and we monitorize, we have to gather data about therapy at each annual visit. And we keep in mind that lung and heart involvement are the most frequent disease-related causes. Also, kidney disease is very severe, but it is less frequent. How we are practically doing this yearly assessment, we take history, we do a thorough clinical examination, And we also do some workup. The workup includes the vital signs, but also an electrocardiogram, an electrocardiography with power Doppler, lung function testing, including carbon monoxide diffusion, and the 6 minutes walk test. And we are doing the lab, which should include, it's recommended that we include in the lab creatine kinase, troponin, and NT-proBNP to check for possible heart involvement. If patients have dyspnea, we think we give them a lot of attention because this might be a sign of heart or lung involvement. And if they don't, they should at least be informed if dyspnea occurs. They should show up quite quickly. About thorax high-resolution computer tomography, this has to be done at least at the first presentation, and if possibly, it should be repeated. If we have a low-dose radiation protocol, we are repeating it on a yearly basis. This is not consensus, so not every center does this, not every center can do this, but it makes sense if we can do serial high resolution thorax CT to also to do it yearly. Because if we find interstitial lung disease, this is the primary tool where we diagnose interstitial lung disease, and it's very important to diagnose it. The severity of interstitial lung disease we assess by doing the pulmonary function tests and also the clinical assessment of respiratory symptoms. And we look at the exercise-induced oxygen desaturation. So until now, everything is fine and clear, and everybody agrees on that. What it's not so clear is how frequently we have to repeat HRCT and how exactly should we define progressive systemic sclerosis associated interstitial lung disease. I shall come back to this when I will show you trial data. But let's think of another severe complication of systemic sclerosis. This will be the pulmonary vascular disease, pulmonary arterial hypertension, which can be a purely vascular disease. This is the group 1 of the WHO classification, or it can occur in association with interstitial lung disease. This would be group 3 of pulmonary hypertension, or secondary to heart disease, group 2 pulmonary hypertension. It is well to be known that treatment options have improved a lot during the last 20 years. And here I am showing you data from a study which was published 12 years ago, and compared patients who were diagnosed in routine practice with PAH. This means they had some symptoms. Only very few were in functional class 1 or 2. The majority were functional class 3 or 4. While when performing screening, we could diagnose a lot more patients in earlier states of the disease. And this is very important because pulmonary arterial hypertension is life-threatening. If left untreated, it used to have in earlier studies a mortality like a survival of only 2 years. So these patients may die if we are not diagnosing them soon enough. This is what led the scleroderma community to develop an instrument to select patients in whom more investigation, more workup should be done to look for pulmonary arterial hypertension. And this is the DETECT instrument. And it is thought to be done in 2 steps. The first step is based on lung function tests, on clinical features like telangiectasia, on laboratory feature like anticentromere antibodies, elevated NT-proBNP, elevated urate, and right axis deviation in ECG. So this first step assumes that most centers can perform these tests. And if there are enough risk factors, these are computed into a risk score and recommends in which patients we should perform echocardiography. Basically, we recommend actually annual echocardiography with power Doppler in all patients. And with the data from echocardiography and the risk calculated in step 1, we can see if patients should have right heart catheterization or not. And more recently, many PAH, maybe pulmonary arterial centers, which are pneumology or cardiology centers, do cardiopulmonary exercise assessment before doing right heart catheterism and manage to dichotomize patients into those who really need the invasive right heart cath and those who don't. And before I am finished with screening, I would also like to remind you that primary heart involvement in SSC is also a dangerous organ involvement. We can suspect it if we see dyspnea, if we have a lot of cardiovascular risk factors, if we suspect it in electrocardiography or echocardiography, or if patients have elevated levels of troponin or NT-proBNP. And in these selected patients, so not in all of them, we do further investigations like a Holter ECG or stress tests, or we refer them to a cardiologist. And there's a lot to be further done as assessment, as workup. This here would be the triggers for further imaging, and for the further imaging, cardiac MRI would be the instrument of choice, because we can see a lot in cardiac MRI. We can see myocardial fibrosis with late gadolinium enhancement, so it has to be with contrast with gadolinium. The fibrosis pattern is different from the one seen in coronary artery disease. If we have a more advanced type of CMR, we can do mapping, T1 mapping and T2 mapping. The one is mostly indicating fibrosis, and the second is important for inflammation. It helps us to diagnose myocarditis, which is quite infrequent, but is a very dangerous complication in systemic sclerosis. And another parameter is extracellular volume fraction, which is indicative of myocardial inflammation and or fibrosis. So we do this only in selected cases. And if we find signs of inflammation of myocarditis, we have to treat aggressively. The third point I wanted to touch is what to avoid in patients with systemic sclerosis. And this point will be quite brief. We are careful with glucocorticoids in systemic sclerosis. It is contrary to what we do in systemic lupus, because there is not so much inflammation in systemic sclerosis, and there is a danger. There is clear evidence that at least higher dosed corticoids bring an increased risk of the scleroderma renal crisis, which is a rapidly progressive renal failure. And this is why we don't do glucocorticoid treatment except for very carefully selected cases. And then we prefer to do low dose, like in patients where we need some treatment for arthritis. But if we can avoid cortisone at all, we would rather do this. And a few cases like myocarditis and severe myositis have a definite indication for high-dosed glucocorticoids. And the rationale behind is that one may die of myocarditis. We may live without kidneys because we nowadays have kidney replacement therapy, but we cannot live without heart. So if severe myocarditis occur, we consider high-dosed glucocorticoids. Otherwise, we would rather not. And the other thing we have to be careful with are ACE inhibitors, so angiotensin converting enzyme inhibitors, which are the very treatment for scleroderma renal crisis. And a lot of studies have looked if we can give them preventively to avoid scleroderma renal crisis. And interestingly and surprisingly, these studies showed the opposite. They showed that patients who received ACE inhibitors prior to having renal involvement, they had a higher risk of developing scleroderma renal crisis. We don't have an explanation to this. We have a nice big studies on more than 1,300 patients in the USTAR cohort. And here is a meta-analysis confirming these results, also with event-free survival, which is less if we use ACE inhibitors. And well, mortality has not reached the statistical significance, but still there is considerable data telling us that we should rather not treat arterial hypertension with ACE inhibitors in these patients, because this might increase the risk of scleroderma renal crisis. And this brings me to my last point, which is a long one: how to treat systemic sclerosis. So here we can see the most important organ system involvements: pulmonary vascular disease, pulmonary interstitial disease, fibrosis, cutaneous disease. If it is diffuse, we might want to treat it aggressively, gastrointestinal disease, and peripheral vascular disease. This is not exhaustive. We might still add myositis, arthritis, Zika syndrome, but I did not intend to present you everything about systemic sclerosis, but the most important points tonight. And now I will tell you a bit of how we choose from these therapies. So we do a tailored therapy. We adjust in every case the therapy based on the clinical presentation. We can begin with vasoactive drugs. We may also need, but not in all patients, immunomodulators, immunosuppressants. More recently, we have antifibrotics, but they only have an effect on the lungs, not on other kind of fibrosis. And in very severe early cutaneous diffuse cases, we may do the autologous stem cell transplantation. Besides all these treatments, we have organ-specific treatments, like I already mentioned that ACE inhibitors are the main treatment for scleroderma renal crisis. We may use symptomatic treatment like proton pump inhibitors for gastroesophageal reflux, and importantly, not to forget, occupational therapy, physiotherapy, nursing, self-care, diet, and so on. So it's a complex treatment. And when we choose treatment, we should take into account what evidence of organ system we can find, the disease subset, because we know diffuse systemic sclerosis has worse prognosis than delimited cutaneous, disease duration, because we may have more complications in the first years since disease onset, since the first non-renal symptom, antibody status like anti-SCL70 or anti-topo antibodies have the worst prognosis, and RNA polymerase antibodies might hide neoplasia. Contrarily, anti-centromere antibodies have the best prognosis. And we also take into account disease activity, disease progression, sex, where male sex is a factor for worse prognosis, comorbidities, and patient preferences. In this slide, I sum up the vasoactive therapy for Raynaud's phenomenon calcium channel blockers. And also, if they don't work, we may add on or may replace calcium channel blockers with phosphodiesterase 5 inhibitors like sildenafil. There is one study for fluoxetine and many studies for prostanoids showing efficacy. Prostanoids, we have to do them intravenously, iloprost IV. So this is reserved for severe cases. If digital ulcera occur, we would give PDE5 inhibitors or iloprost or even both to heal more quickly this ulcera. We have to do wound care to keep this ulcera non-infected. And if they tend to occur, we would use this endothelin-1 receptor antagonist bosentan. And for complicated digital ulcera, we have other treatments We can consider platelet inhibitors, analgesics, antibiotics, and not so evidence-based botulinum toxin in the fingers or even sympathectomy. If we are addressing pulmonary arterial hypertension, you may find some of the drugs already mentioned with Raynaud's and Ulcera here, except calcium channel blockers. Those don't work. And in renal crisis, ACE inhibitors are the mainstay of therapy. They should be given early, dosed aggressively. And if we cannot control the high blood pressure, then we may add calcium channel blockers or even bosentan, which is more and more considered as a treatment of renal crisis, but not alone, but in association with ACE inhibitors. So I will skip, let me go to this slide to talk about management of scleroderma renal crisis first. So as I said, if we suspect it, we would like to hospitalize these patients, promptly institute treatment with ACE inhibitors. If not sufficient, add second line, this is calcium channel blockers, at third line, other antihypertensives, and in very severe, in catastrophic cases with other organ system lesions with severe thrombocytopenia, thrombotic microangiopathy, we consider doing plasma exchange. There might be a role for the biologic eculizumab blocking complement. In some patients with catastrophic scleroderma renal crisis, we might use iloprost, and of course we have to do kidney replacement in severe cases, and some patients have to remain lifelong on kidney replacement. Renal transplantation is not contraindicated, so in the long-term treatment of renal insufficiency, we are considering renal transplantation. The other severe vascular involvement is systemic sclerosis associated pulmonary arterial hypertension. This is a complex algorithm. From this, I would like to point out two aspects. It is mostly not responsive to calcium channel blockers in contrast to idiopathic PAH. And we are favoring initial oral combination. This means that only very few cases are receiving monotherapy with endothelin antagonist or PDE5 inhibitors. We mostly start with a combination of these oral drugs. And if it is severe, this is assessed based on the risk. They even may start on triple combination, including intravenous prostanoids. The treatment, the diagnosis and treatment of PAH is traditionally done in specialized centers where pneumologists or cardiologists are treating these patients. And this is why when I suspect PAH, I always refer these patients to pneumologists in my center who will do cardiopulmonary exercise testing and right heart catheterization. And if they find PAH, this means group 1 pulmonary arterial hypertension, they would start the treatment. What about fibrosis? So the most information we have for treating fibrosis is coming from scleroderma lung disease trials, lung fibrosis trials. And we have these 5 drugs to deal with. The most ancient treatment is cyclophosphamide. The scleroderma lung study was published 2006. Actually, it did not meet its primary endpoint, which wanted to check for statistically significant differences in changes in forced vital capacity at 12 months between placebo patients and patients receiving oral cyclophosphamide for 1 year. But these two groups showed significant differences at 18 months, even if treatment was restricted to 12 months. And then the treatment effect was lost. So this led to cyclophosphamide to be the #1 treatment for SSc-ILD in elder in more old guidelines, but this has changed now because we have less toxic immunosuppressive than cyclophosphamide, and this is mycophenolate mofetil. 10 years after the scleroderma lung study, it was scleroderma lung study 2, which was published. They compared 1 year of cyclophosphamide to 2 years of mycophenolate mofetil. And they aimed for superiority of mycophenolate at 2 years, which again was not achieved. So again, a study which was negative in its most primary endpoint, but from this very well-powered study, we can still draw the conclusion that mycophenolate works as good as cyclophosphamide with lesser toxicity. Another study, and this is a very big one, published 3 years ago, looks at treatment with this antifibrotic nintedanib, which is approved for idiopathic lung fibrosis since almost a decade. And it has a huge number of systemic sclerosis patients, almost 600, and it has significant results at 6 months and also at 1 year. In terms of change in forced vital capacity. So this has led to the approval of nintedanib in America and in Europe for treating systemic sclerosis-associated lung fibrosis. And another thing to take from this study is that background treatment was allowed with immunosuppressants. So about half of patients had stable baseline mycophenolate. And this sub-analysis shows that the group with the best course was patients who had nintedanib and mycophenolate. In contrast, those who only had placebo had a more severe loss of forced vital capacity, and the ones who had only mycophenolate here and only nintedanib were more or less similar, but okay, we are not allowed to compare this. So the conclusion we draw is that we may associate these two drugs. One is an immunosuppressant, the other is an antifibrotic, and we aim for better disease control in systemic sclerosis-associated lung disease. Then we have the biologics, and there have been 2 big tocilizumab trials, phase 2 and phase 3. We had a lot of hope from this phase 3 study, which aimed to control the disease as a whole. And it used this surrogate endpoint, the Rodnan skin score at the end of the placebo-controlled duration, week 48. Between placebo and tocilizumab patients, they were not allowed to have background therapy, but escape was possible. So they only got immunosuppressants like methotrexate and mycophenolate mofetil. Hydroxychloroquine is not an immunosuppressant, only if they had worsening skin or lung disease at 16 to 24 weeks. And what is the result of this study? Disappointingly, it was a negative result in terms of primary endpoint, although we see quite a tendency for more improvement in the tocilizumab arm, but it's not statistically significant. This means tocilizumab could not get an approval as a disease-modifying therapy for systemic sclerosis. It still had very good results for lung fibrosis. Although this study was not performed in lung fibrosis patients only. So patients could be included if they had early diffuse active systemic sclerosis with or without any lung involvement. It was never mind sufficient to show a definite effect on lung fibrosis. So this led to the approval by the FDA for tocilizumab in SSC-associated interstitial lung disease. What about the other biologic, rituximab? We have it since longer than we do have tocilizumab, and there have been a lot of studies with not so concludent results. Until 2 years ago, this Japanese study was published showing good results in skin and also in lung fibrosis. And this doesn't mean this treatment is approved for treating systemic sclerosis, but it gives us more courage to treat with rituximab. And before finishing with disease-modifying treatment, I have to tell also about hematopoietic stem cell transplantation. It is autologous hematopoietic stem cell. This means from the patient. And it is a very effective treatment. It shows significant and long-standing improvement in all aspects of the disease, especially lung function, skin thickness, but not only. But it has quite some risk. So the procedural related deaths amounted to a bit over 5%, 6.3%. It took a lot of time to recruit patients for these randomized controlled trials. This is a meta-analysis of 3 randomized controlled trials plus a lot of observational studies. And we can see worldwide that the treatment-related deaths tend to decrease because the centers get more experience. But because of this risk, we would do it only in a small number of patients. And to finish with how we treat interstitial lung disease, very recently, a few days ago, these recommendations have been published. They come from the American Thorax Society, and they tell us mycophenolate is like number 1, and all the others are number 2. But I have to tell you, there are patients in whom I would begin with another drug than mycophenolate if I see other organ system involvement that could benefit from that. For instance, I can use one of the biologics if patients have arthritis. And of course, not to forget the other treatment possibilities. We shall see next year this upcoming Schuller recommendation for the management of SSC coming up. They have been presented as an oral presentation at the Schuller Congress this year. And some of the treatments we discussed extensively, like pulmonary hypertension and vascular complication and interstitial lung disease. We don't have much evidence-based treatment for musculoskeletal disease, where we tend to apply methotrexate first. And for gastrointestinal symptoms, where we treat symptomatically. I'm almost done with the presentation, so I think I touched all these 4 points. Of course, there would be a lot of details to discuss, but I think this has already been a lot of information. I will sum up with these take-home messages, like we would like to diagnose the disease as early as possible. This is why we screen patients with Raynaud phenomenon, especially if they also have puffy fingers. We do in these patients antinuclear antibody testing and capillaroscopy. Then if we find systemic sclerosis, we want to screen regularly all the patients for organ system involvement, especially to check for SSC, interstitial lung disease, by high-resolution computer tomography. Of course, we do a thorough history and clinical exam. We do lung function tests, 6 minutes walk test, electrocardiography and echocardiography, and we apply the DETECT screening instrument for assessing risk for pulmonary arterial hypertension. We avoid, if possibly, glucocorticoids and ACE inhibitors. And if we find symptomatic systemic sclerosis associated interstitial lung disease, or if we find PAH, also if it is asymptomatic, or if we have signs of renal crisis, we want to institute treatment immediately. For fibrosis, we have mycophenolate mofetil, cyclophosphamide, tocilizumab, rituximab, nintedanib. The first 2 work also for skin disease, but we would not give these immunosuppressants for skin disease only. In pulmonary arterial hypertension, upfront combination oral therapy is to be instituted. We have lung transplantation and autologous stem cell transplantation in very severe cases. And we have quite a well-developed treatment for scleroderma renal crisis. I am done with this. I am very thankful for your attention. I want to acknowledge my group led by Professor Oliver Distler, and this is my research team, and I'm very happy to take questions.
Congratulations, Professor Mihai, for your amazing and clear presentation. Very interesting. You have shown us how complex is the management and the treatment of these patients. You are perfectly on time. Now the discussion is open. Let's start with the first question. The first question is the following. Is there a relationship between the extension of skin fibrosis and the extension of cardiac fibrosis in these patients?
I'm very grateful for the question. This is a very important point. Actually, we expect to see cardiac fibrosis in patients with diffuse cutaneous disease, with early disease, who have a more accelerated pace of skin fibrosis worsening. But we sometimes have surprises, like seeing it in patients with the so-called systemic sclerosis, sinus scleroderma, where we don't see any cutaneous fibrosis, but we still may find fibrosis of internal organs, but that is the exception. So yes, there is a correlation between cutaneous fibrosis and heart involvement and organ involvement, but there are exceptions to that.
Thank you, Professor, for your answer. The second question is if cardiac fibrosis is reversible or not.
I think there is a lot of research going on this topic. So for the moment, we don't really know. The instrument of choice to assess this would be with CMR, with cardiac MRI, with T1 and T2 mapping. The T2 mapping, the T1 mapping, and the extracellular volumes are the instruments of choice to quantify fibrosis. And of course, it's difficult to do serial CMR in patients and costs a lot of money, but these studies are going on in some centers. So I hope in the near future we'll be able to answer that question. For the moment, we actually don't really know how to treat cardiac fibrosis. We tend to give mycophenolate. We hope the biologics might bring something, but we are not really sure. So there's a lot of research going on.
And again, third question is if patients with systemic sclerosis are more prone to develop hematological cancer.
This is a very righteous question, but the answer would rather tend to be negative. In systemic sclerosis patients, we are very aware that those who have the RNA polymerase III antibodies are more prone to develop cancers. It is mostly solid tumors, but basically any type of cancers would be more frequent in these patients. This is why we do a very thorough neoplasia screening in these patients when we first diagnose them, even with a PET CT if possible. And we repeat the screening, maybe not the PET CT, but we are keeping an eye on the neoplasia risk, like in the first 5 years since we diagnosed them with systemic sclerosis and these antibodies. In the other systemic sclerosis patients, the incidence of cancer in general is not very high compared to general population, but it is a bit higher than in general populations. But it is not hematologic disease that we would more expect. In the last year, I had some cases of lung cancers, and in the previous years, I had some breast cancers in my patients. So yes, cancer may occur of any type. They are lucky to have this yearly screening because we take a look and we mostly achieve an early diagnosis of cancer.
Thank you very much. The next question is is there a place for low-dose aspirin as a prevention in all systemic scleroderma patients?
I love this question. This is what we also have been asking for years, because there was no evidence covering this. We tended to give low-dose aspirin in patients with severe peripheral vascular disease, like recurring digital ulcers, severe Raynaud's, and we really didn't know this until my colleague Alexandru Garaiman and Mike Becker, they took a look 2 years ago at the USTAR database and analyzed the data of this very large database regarding the association of platelet inhibitor therapy and occurring of new digital ulcers. And they find out, I'm really sorry I didn't show you this slide, they found out that patients who already had platelet inhibitors in place, which we are not giving mainly for systemic sclerosis, had a lower risk of developing new ulcers. So now we believe we can give these treatments to prevent digital ulcers, although there is no randomized control study to support this. We have this information coming from a retrospective cohort study.
Thank you. Another question regarding how to manage patients with Raynaud's syndrome, but patients that don't meet the criteria for systemic sclerosis. Should we search for other autoimmune disease? How to manage this patient?
Yes, very good question. We actually recently opened a clinic for patients with Raynaud's phenomenon because we screen possibly secondary Raynaud's in practically all patients. Of course, the risk is low if a patient has Raynaud's beginning in the youth, like as a teenager or in the early 20s. There is where the primary Raynaud's is mostly found, and it is mild and not progressive. But in 1/3 of all Raynaud's patients, they have something underneath the Raynaud's phenomenon, which might be atherosclerosis, might be a systemic autoimmune disease, might be drug-related, might be also be related to blood hyperviscosity. So we have this approach to seeing patients with Raynaud's, and we do capillaroscopy. We are checking for anti-nuclear antibodies in immunofluorescence, and if we find positive results in immunofluorescence, then according to the immunofluorescence pattern, we check for those antibodies. And of course, we are seeing these patients and checking with history and clinical exam for connective tissue disease associated symptoms. And we do some other lab tests besides antibodies. So they could have other immune diseases like rheumatoid arthritis or other connective tissue disease. Also, Sjögren is having a high prevalence of Raynaud's. So the answer is yes.
Thank you. I have one comment and another question. The comment is from Georgescu Mihaela, who is a dermatologist from Romania, and she wants to say thank you for the presentation.
Thank you. I know her, and I'm happy she attended, and I say thank you too for attending.
And the next question is, may you repeat why to avoid ACE inhibitors?
So this came as a surprise to the whole scleroderma community. So previously, this is a very common medication for systemic arterial hypertension. So I used to give it without any second thoughts in patients with systemic sclerosis and systemic arterial hypertension, essential hypertension. And then there were these studies who actually wanted to find if we can prevent scleroderma renal crisis using ACE inhibitors. So again, retrospective studies based on these prospectively collected data in the USTAR cohort and in other smaller cohorts. But in the meta-analysis I showed you, the USTAR study had the vast majority of patients from the meta-analysis. And they were shocked to find the opposite, they double checked, they did the analysis a couple of times, not to have missed anything, like, you can label the patients the other way around and then you get the opposite conclusions. But no, this is very well demonstrated that patients who already had ACE inhibitors had a slightly higher risk to develop scleroderma renal crisis. It was not sky high. It was like an odds ratio of 2 point something. But this would make me reluctant if I have to treat systemic arterial hypertension in someone who has risk factors for the scleroderma renal crisis. And I didn't go into that today, like which are the risk factors. SCL70 antibodies, early disease, diffuse cutaneous disease. This is the risk constellation where we expect a higher risk for scleroderma renal crisis. In these patients nowadays, I would really avoid ACE inhibitors and I would prefer treat hypertension with calcium channel blockers and other antihypertensive drugs.
Thank you. Another question is the following. Are there any predictive factors for scleromyositis in patients diagnosed only with systemic sclerosis?
Yes, muscle disease is having a broad spectrum in SSC. This means from patients who only have some myalgia and some slightly elevated CK levels to overtly blown polymyositis with muscle weakness, muscle atrophy, and so on. We would expect myositis to occur in patients who have the PMSCL antibodies. These are quite specific to a subset of patients who are quite having an overlap clinical presentation between systemic sclerosis and dermatomyositis. They tend to exhibit disease features of both diseases. And another predictive factor would be SSA antibodies of the Rho52 type. And well, I think I can close my list. So these antibodies are the things that associate with myositis risk.
Thank you. Would you follow up systemic sclerosis antibodies in asymptomatic persons clinically or with yearly pulmonary functioning tests and other internal organ tests?
This is a question I meet with in clinical practice when somebody gets referred only with antibodies and no symptoms at all. So we are mostly having a first consultation, including lab tests and systemic and nail fold capillaroscopy. And if in this clinical examination and history and capillaroscopy we don't find anything, then we label the case immune constellation antibodies only. And we tell the patient and the referring physician that we would like to repeat the consultation only if symptoms turn up, like Raynaud's or any other symptom compatible with connective tissue disease. Otherwise, we would not repeatedly look at these patients. If we check first-degree relatives of patients with lupus, I think the study has been done in families of lupus patients. About 50% of these relatives who are healthy, they have antinuclear antibodies. So the mere fact of having the antibody is not leading to the disease development, but they have a slightly increased risk. And then we have this very nice study I showed you a slide about, the Koenig studies with Raynaud's phenomenon patients who were checked for antibodies and nail fold changes. And you saw that the ones who only have antibodies and Raynaud's, but normal capillaroscopy, had about 20% risk to develop systemic sclerosis in 10 years. And these patients I would check at least every other year if they have Raynaud's and some other feature, but not the fully asymptomatic ones. If they have Raynaud's and some other feature, we would label them very early systemic sclerosis. And then the practice differs among centers. In Zurich, we are checking them, if not yearly, then every other year with the whole organ screening tests battery. But this is because we have quite a good system that allows us to do a lot of workup in these patients, and the insurers pay for it. If they wouldn't, it would be a problem.
Okay. Another question is, which is the first antihypertensive drug for the treatment of hypertension in patients with systemic sclerosis?
Yes, we are very much inclined to use calcium channel blockers because we would, in German you say, kill two flies with the same hit. So yes, calcium channel blockers like nifedipine, amlodipine, dihydropyridine. And we are a bit reluctant with beta blockers, but if they are very specific, we might give them a try. We don't know if angiotensin receptor blockers have the same risk as ACE inhibitors, so we tend to use angiotensin receptor blockers, but of course the first line of choice would be calcium channel blockers. And I think I already answered the next question about beta blockers. So we would avoid unselective beta blockers like propranolol and also carvedilol, but not with the others. We might try. It depends on the indication.
Thank you. What can be prescribed for chronic pain in early systemic sclerosis to avoid patient overuse of NSAIDs?
Chronic pain is a difficult aspect, and I thank for this comment because we sometimes see the full-blown picture of fibromyalgia in scleroderma patients. And this is a thing we don't understand very well. So, you know, fibromyalgia, we have some idea it is a centrally occurring pain. So it's not a nociceptive pain. And we have a very complex approach with exercise. Sometimes we can give antidepressants. This is if the picture is of fibromyalgia and not of arthritis. Of course, we can see a mixture of the two. If we have arthritis in patients with SSC, we lack randomized controlled trials, and we tend to treat this arthritis with methotrexate, or we can even use biologics like rituximab and tocilizumab like we do in rheumatoid arthritis. In some patients, we have very good results, but not in all of them. And we tend to believe that mycophenolate and cyclophosphamide are not so well in controlling arthritis. This is like expert opinion, not evidence-based opinion.
Thank you. Another question is the following. Would you recommend topical nitroglycerin cream to all Raynaud's patients, or in selected patients, or in particular situation, for example, during winter season?
I confess I don't have a broad experience with topical nitroglycerin. In most countries, we don't have good ointments with that. In Switzerland, there are a few ways to get that, but then they complain it's greasy and they didn't much like it. So the mainstay for Raynaud's would be cold protection. And then we have occupational therapists who can teach our patients a lot of tips and tricks with cold protection. They have pocket warmers, they can have heated gloves, they can learn how to keep themselves warm. And actually avoiding cold is so very important that I cannot really stress it out as it deserves, cold avoidment.
Thank you. We have one more question. Does Raynaud phenomenon present differently in patients with darker skin color?
Thank you for the question. I think it is a bit more difficult to see it, but they still can tell they have pale fingers. So in the cohort Zurich is ethnically quite varied, not so varied like cohorts in the United States, but still we have, I think, like 30% who are not born in Switzerland. And what I can say is if the skin color is dark, we have some trouble performing capillaroscopy because pigmentation is diminishing visibility in capillaroscopy. But patients with darker skin color can still tell they have Raynaud's or tell they don't. So I think it's not so bad with Raynaud's. We can still diagnose it on history.
Thank you again, Professor. There are no more questions, so we can close the webinar. Before ending, I would like to thank all the participants, the Professor Mihai for accepting the invitation and for her amazing presentation. My colleague Max Schuller for co-moderating the webinar together with me. And last but not least, our chief, Carina Mihai, for the organization of the webinar and for the work she has done. I hope to see you all face to face in the next EFIM events. Have a nice evening.
Thank you so much. Have a nice evening too.
Thank you again.
Thank you, everybody.
Thank you. Bye.
Thank you. Bye-bye.